Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Dr. Sandra Herrmann in Rochester, Minnesota, with whom we would like to discuss acute kidney disease in patients who receive immune checkpoint inhibitors. Sandra, thanks so much for being our guest tonight.
Thank you for having me. My pleasure.
Dr. Herrmann is a nephrologist and she's associate professor of medicine at Mayo Clinic in Rochester, Minnesota. A focus of her clinical and academic work is the field of onconephrology, particularly acute kidney diseases that are caused by hematological diseases and nephrotoxicity of novel cancer treatment agents, particularly immune checkpoint inhibitors. So this is hardcore onconephrology, and I'm delighted to have two co-moderators who are themselves experts in hemato-oncology and immune kidney disease, respectively. Professor Dominik Wolf, who is head of the Department of Hematology and Oncology at the University Hospital of Innsbruck, Austria, and Andreas Kronbichler, who is board member of the Young Nephrologist Platform of the European Renal Association. So I think, Andreas, the first time that we have four colleagues from 4 different countries, because Andreas actually also comes from Innsbruck, but right now he's in Cambridge, UK. So a pleasure to have you all. And we decided to start the talk by Professor Wolf giving us an introduction. What are actually checkpoint inhibitors? I'm aware that younger colleagues did learn this kind of medication at medical school, but elder colleagues like me actually did not have any kind of checkpoint inhibitors when they went to medical school. Therefore, it's a pleasure if you would give us an introduction before we come back to nephrology.
Okay, thank you very much for the very kind invitation. It's always cool to cross borders between different disciplines, and I think it has never been that important as today. And today I'm really happy to join this small round of discussion group, and I would like to start with showing you some introductory slides. As you already said, I'm at Innsbruck University Hospital here and responsible for Hem-Onc. So we use those drugs really a lot. So as you all know, it starts with huge pioneers, and perhaps you've seen this article from Ron Germain published in the New England Journal of Medicine, and he was referring to the awards of the Albert Lasker Basic Medical Research Award to Max Dale, Cooper, and Jack Miller. And they have received their awards for their groundbreaking work by showing that lymphocytes are not only lymphocytes, but they are subgroups of lymphocytes, and where they arise from a common lymphocyte or lymphatic progenitor, which then differentiates either in the thymus into T cells or in the thymus and the bone marrow into B cells. And this is the ground work for the developments over the last decades, which have led to the ability to use antibodies for cancer therapies, but also in your fields, I mean, for treating immune-mediated glomerular diseases, for example. And to use T cells for cancer therapy is something many people have really also pioneered. This ranges from using, for example, tumor-infiltrating lymphocytes. This is the pioneer of this field. He's still active, Steve Rosenberg. So he tries to isolate lymphocytes out of tumors, expand them, and reapply them to patients. And this can be based on analysis of T cell receptor cloning, and also with the idea to re-express or clonally expand tumor-reactive T cells. But actually, the idea is to take out lymphocytes from the tumor microenvironment and to use them for therapies. You may all know also Carl June. He's really a huge pioneer of CAR T cell technology, and this is something we increasingly use in our unit, but many hematologists for using of lymphomas. But you have probably also seen that this can experimentally be used also for lupus. For example, you have seen probably the publication in New England Journal of Medicine, where CD19 CAR T cells have been used to treat drug resistance lupus erythematodes by the Erlangen group. So this is a technology where you transduce T cells. But the idea is also to activate endogenous T cells here by giving them an artificial T cell receptor, a chimeric T cell receptor. This is Ralf Bargou. He has pioneered, he's still active in Würzburg, he has pioneered the use of small B-specific antibodies, which bridge between tumor cells and T cells and activates the T cells against the tumor. Also, here the idea is to activate endogenous T cells. And last but not least, Allison and Honjo have received the Nobel Prize for Medicine, you may know this, in October 2018, for their groundbreaking work, and this is what we will cover today, for the use of checkpoint antibodies. So these antibodies are able to reactivate exhausted, so let's say tired T cells to fight the tumor. There are different targets, different approved checkpoint antibodies. So the so far mainly used checkpoint antibodies are the ones which interfere with the interaction between PD-L1, so PD ligand 1 and PD-1 on T cells, which infers an inhibitory signal. So if tumor cells have high expression of PD-L1 and T cells are PD-1 positive, which they are usually when they recognize, when they activate it, that happens in your body as well. If you for example, get infected with COVID, you have a T cell expansion, and afterwards the T cell expansion is limited by upregulation of negative regulators such as PD-1 on T cells. And this is something which is a physiological phenomenon which we all use to prevent overactivation of T cells. But here in this case, this can be chronically used by T cells to put in, to overrule the activating TCR, so antigen presentation of a tumor-associated antigen, which not usually would activate the T cell. And here you infer a negative overruling signal, which inhibits the T cell activation. So thereby the T cell is not able to destroy the tumor cell. And if you block this, either by blocking PD-L1 or by blocking PD-1 with inhibitory or blocking antibodies such as nivolumab, pembrolizumab, atezolizumab, they're all approved in different areas, you can reactivate the T cell. But think about what I've just mentioned. It's a physiological thing. And if you look at PD-1 knockout mice, they get autoimmunity. And that is also the link to what we will, what mainly you will discuss, as you are the experts. Actually, I'm just destroying the kidney. So then I need help from nephrologists, for example. So actually, this is something where you can already expect some kind of side effects. The CTLA-4 is the second important immune checkpoint, and this is also something which does not necessarily play a role in the interaction between tumor cells and T cells, but more at the so-called immunological synapse. So where you have an antigen presenting cells, for example, a dendritic cell, which comes from the tumor, and it has taken up dying tumor cell material, and usually it presents tumor-associated antigens to the T cells in the lymph nodes. And also here we have inhibitory signals which compete with the activating co-stimulatory signal, here signal 1 T cell receptor, signal 2 CD28. So this usually, if you have low expression level of CTLA-4, the T cell gets fully activated. But if you have high expression level of CTLA-4, this can also counteract this adequate T cell receptor activation cycle. So, and also here you can interfere with blocking antibodies. This is, for example, ipilimumab. And you also know that in rheumatology, you can use agonistic, CTLA-4 agonistic compounds to actively inhibit T cells. So you use the same principle there. And this is, I think, it's highly interesting. And I mean, this is just an overview. We can't go into details, but you see that some diseases are very sensitive towards immune checkpoint inhibitors, for example, melanoma, non-small cell lung cancer, head and neck, uro-oncology, but there are many other diseases such as prostate, for example, where the swimmer's plot, where the plots do not look that positive, where you have less responder, and where those drugs, at least at single agents are not very active. But they really changed, they are game changers. I mean, they have not, and therefore they have been awarded by the Nobel Prize of Medicine. This is a 75-year-old gentleman. He had, in 2013, first diagnosis of non-small cell lung cancer, non-squamous, stage 4 at the beginning, no oncogene driver. He was treated until 2015, and then at this time point, he had no further treatment option, except this was the first patient who was treated in Innsbruck in the expanded access program, and you can see complete remission and only one lymph node which arose, slow progressing lymph node, so secondary resistance. This was irradiated, and this gentleman is still in complete remission now, 2022. So it's 9 years later. But there are also bad examples, and you can see here that the main problem is resistance. So overall survival for some individuals is very long, is going up to 1 decade, but actually many of them do have primary or secondary resistance, and this is shown here. But please keep in mind, there are side effects. I've mentioned this, and today we have to discuss renal side effects. That's your profession, you are the experts, and I think that all depends on the physiological function of immune checkpoints in regulating T-cell responses. And this can, if you block those immunological, physiological immune regulators, this can also harm various organs, including the kidney. And I think this is important to know. This is a case report of a patient which had a severe myocarditis, just to sensitize you. I haven't seen that severe renal side effects, meaning really severe. This patient has a severe myocarditis, and this just shows you need steroids, then you need some kind of support. And in this case, we needed cardiologists. In other cases, we need to work interdisciplinary, and we need to know where to look up the guidelines. And here are two of the most important. This is a very extensive review published in JCO, which doesn't help in very specific questions, but overall it helps you a lot in thinking about how do I manage this particular side effect. And with this, I would like to end, and I think we can go over to the discussion.
Thanks for this brilliant overview. Now we learned who destroys the kidney, and now it's up to you, Sandra, to help us to refix the kidney. And I would like to start and ask you to give us an estimate how many patients will face kidney-related side effects if they receive checkpoint inhibitors.
Overall, all the patients receiving immune checkpoint inhibitors in several studies have shown that around 70% of these patients will have some kind of acute kidney injury, but that specifically relates to immune checkpoint inhibitors. Obviously, depend on the study case series, it's around 2 to 5%, sometimes 6%. But we can agree that somewhere between 2 to 5% depends on the type of immune checkpoint inhibitor also, especially if you're going to receive a combination therapy, that's a higher chance to develop immune checkpoint inhibitor associated AKI. It can go to 5%, especially using CTLA-4 inhibitor or PD-1 or PD-1/L1 inhibitor.
And what are the most frequent types of side effects as affects the kidney?
So the most common side effects is acute interstitial nephritis. We can say about at least 80 to 90% of the patients who develop immune checkpoint inhibitor associated AKI is going to present with acute interstitial nephritis. There are other pathologies that have been described, including nephrotic syndromes, nephritic syndrome. From the nephrotic syndrome side, most common podocytopathies like minimal change disease or FSGS type of lesion. And for nephritic syndrome, the most common type is vasculitis, and it can be associated to positivity to ANCA in the blood or not.
Are there any risk factors which may help us to identify before starting treatment those patients who are at highest risk for kidney side effects?
Yeah, there's a few risk factors that are being shown in different studies. The most recent, the multi-center international study found that lower eGFR, patients who have lower eGFR that have more risk, and this could be just because they have lower reserve, kidney reserve, and then most likely you're gonna notice this. But use of AIN-related drugs like NSAIDs, PPI, some antibiotics that in some patients, may lead to acute interstitial nephritis they might develop. And the other risk factor is like combination therapy that can cause checkpoint inhibitor associated AKI.
So what about patients who have a history of kidney disease like minimal change GN, which is in complete remission? Should we be more reluctant to apply checkpoint inhibitors to these patients, or should we just follow the recommendations from the hemato-oncologists as if the patient had no history of kidney disease?
That's a good question. Like from my experience, some patients, ideally when the oncologists, they all have a UA before starting or some kind of kidney evaluation. And sometimes you think the patients that developed de novo, but they already have. The patients that I have who had, for example, a patient who had the anti-GBM disease, didn't develop it again. Patients who have IgA nephropathy incidentally, some might develop, some others not. I think you should not prevent any patients who have glomerular disease to receive, because those drugs are ideally especially for some type of cancer like melanoma. Dr. Wolf has shown that they really respond. But there are mechanisms that you can use to try to, if they develop acute kidney injury or flare up of their disease, that you can use to try to put this glomerular disease on remission. I would not have any restrictions, but obviously those patients who have autoimmune diseases, they have a chance to flare up during the treatment.
Because I guess it's not clinical practice that each and every patient who receives checkpoint inhibitors has a urine check-up before, but surely Dr. Wolf can contradict this. I guess you would have a creatinine value in all patients, but does the oncologist do urine examinations in all patients before starting treatment?
You mean urine
albumin excretion, yeah.
Where we do the normal urine status,
okay, yeah.
which is not a examination of the urine sediment. This is something we do not regularly do. But I would say, I mean, based on what I completely agree with what you said in terms of metastatic patients, which do not have an appropriate alternative. But the checkpoint inhibitors are coming more and more also into the adjuvant setting, where the net benefit of, for example, atezolizumab, which is now will be approved for adjuvant treatment of patients with lung cancer, is pretty small. Let's say it this way. There's a clear effect on relapse-free survival, not yet on OS, but actually this will lead to approval. And in this particular setting, I think we have to weigh risk and benefit. And if you have a patient which has a history of glomerular disease and is in remission, and we have a benefit which is okay, it's there, but actually it's not that, it does not affect OS so far. I think we have to be a bit more conservative in those patients as compared to metastatic high PD-L1 positive, where you say, okay, this patient, chemo is not very, you have to apply cisplatin, which is also not very good for the kidney. And I think, so we have individually in the curative adjuvant setting, I think we have to be a bit more conservative, because we do not have the patient, if he or she has really severe acute kidney injury. In my impression, even though we use those drugs very often, we do not very often use PD-1 CTLA-4 blockers, because this is mainly used by the melanoma people. We use usually PD-1 blockers or CTLA-4 blockers alone in combination with chemotherapy. And in these patients, I would estimate that the really severe kidney damaging effect is below 1%. So it's not more than 1 out of 100, where you can really clearly say it was the checkpoint antibody. I mean, if we treat with platinum, for example, in non-small cell lung cancer, we often use cisplatin, pemetrexed, pembrolizumab, for example, in a combination. Those patients often have have kidney problems, but actually this is, at least this is our impression, this is frequently more a tubular problem and not a glomerular problem. I don't know how you interpret these statements.
No, I agree. When you don't have any other, possible drug, it's important to, I don't think we should prevent any patients who has no other alternative to use those drugs, because for some case, I have seen some cases, they're like, as you said, miracle drugs. They really, specific patients, somehow they really respond well to these drugs. Yeah.
So before returning to interstitial kidney disease in a moment or two, just one question about other complications like electrolyte disturbances that also may occur in these patients. Would you give us a brief overview which kind of electrolyte disturbances may occur and which may be the underlying pathogenetic reasons behind it?
Sure. There are, as any cancer patient, they always have a lot of electrolyte disturbance because sometimes they're using with other medications as well. But hyponatremia, hypokalemia are very common electrolyte disturbance that we see in this patient population. For the case of hyponatremia, there's some case associated to autoimmunity or prostate-affected hypophysis. Can occur mechanism, adrenal glands can be affected, but those endocrine type of complications are very common to see. Most commonly, you see some degree of hyponatremia that we expected with, I think, any oncological treatment, but those who are more severe are very low, like 6% of the patients have really low levels of sodium below 125, 124. And from those 6%, just like 0.3% are really related to endocrinopathies for a case of hyponatremia. Hypokalemia, you also can see, I see hyponatremia, hypokalemia mostly in the patients who have CTLA-4. I believe that because CTLA-4 inhibitors can cause a lot of GI, gastrointestinal disturbance as well. They have nausea, vomit, colitis. And I think those patients we see most commonly those type of electrolyte abnormalities. Particular from what is related to the kidney, some first case report described in France, they related patients presented with renal tubular acidosis. And interesting, after that case, we start like reviewing the cases that patients have just mild AKI, creatinine was baseline 0.9 to 1, but they have severe non-gut metabolic acidosis. Some would have a hypokalemia associated that was more like distal tubular acidosis. And since I'm kind of a translational, I got the pathologist, these patients discussed with Dr. Romero, that's an expert in the area. And he stained the phenotype for annual exchanger, VATPase channels, and he found that very similar to patients who have Sjogren's disease, the autoimmunity, they do present with the interstitial nephritis and distal tubular acidosis, and they have the same phenotype. And we had a control, and these two cases will have the biopsy, which is not very common to see, but because we know we are more aware, we are able to get a couple of biopsies and stain. And they are very similar, the mechanism of immunity of Sjogren's, which I think it's, represents what these drugs do. The kidney, other, hypercalcemia has been described as well. I think a lot of this can be associated to the tumor per se, but hypocalcemia has been present and metabolic disturbances as well.
And are there recommendations for a fixed interval between which one should check electrolytes in these patients, or it is rather on an individual basis?
I think as in oncology, they check every month or every time they come the next checkpoint every 2 weeks, depends on the schedule of the immunotherapy. They check a full chemistry panel of these patients, and then you can see if they're developing electrolyte abnormalities. I would just go for the oncologist care, but obviously if they are developing those symptoms, they may need to be checked more frequently.
How often do you consider kidney biopsy? Or actually, I guess you consider it quite often, but how often do you do kidney biopsies in patients now coming back from electrolyte disorders, surely to interstitial and glomerular kidney disease? And in those in whom you do kidney biopsy, could you give us some idea about the most frequent findings you'll have?
Yeah, we don't biopsy everyone. You know, we just biopsy those that initially we see there is no other cause. As I said, approximately like 70% have AKI. Many of these causes are because, you know, hemodynamics changes, the patient get volume depleted, they can be obstructed, or even other chemotherapies can be causing the drug. When you cannot really rule out other causes, you may consider the kidney biopsy. At Mayo, we use those tools where we publish about evaluated those patients who come with acute kidney injury, have the CRP measured, and we measure retinal binding to creatinine ratio. They usually have a very low levels in patients that do not have any kidney injury. And they are much more helpful for those who have very mild degree of AKI than those who have acute kidney, like grade 2 or higher AKI. I can differentiate much better when the oncologist, here at Mayo, we call very easily each other, and they like patient had a creatinine of 0.9 or 1 milligram, and then the creatinine is 1.3, 1.4, and they come for the next dose of immune checkpoint inhibitors. And then they call, what do you think? I ask you to check CRP and retinal bind. If both are low, unlike like low probability they develop, they are having AKI because of that. I ask, patient is drinking, do they have loose stools? Maybe it's some other cause. Many times they say, the patient, they live far away, they don't want to come, say, go ahead and give it the next dose. We ask, they check, you know, closer home in a week, everything is okay. And most of the time, and that's why it led us to do our study and look at these biomarkers, if they are negative, we are much more comfortable saying no need of biopsy. If I don't want CRP or retinal binding protein to creatinine is elevated, then we think this is something happening. I have to say for retinal binding protein and creatinine ratio, any type of tubular injury is going to increase those levels of those proteins. But if it's the CRP is negative and they are on platinum therapy, we're really in doubt. That's why it takes me, well, I think we need to do a kidney biopsy to find out what's going on. And some of these patients, they just receive a dose of dexamethasone with other, and then you see the CRP is low at the time you see them. You can just hold on therapy if the patient have some contraindication for the biopsy. But if the creatinine continue to increase and both of the markers are high, and I cannot biopsy this patient, or the patient doesn't want to do the biopsy, we consider a trial of treating empirically with prednisone and check next to is that getting better or not, you know, and that's how. I think they're very helpful, at least to help with the rule out, with the therapy, or wait until you see if something is just starting or it's going to happen the next few days or week.
I'm also starting with a question towards liquid biopsy, because, you know, all these patients have some comorbidities and some are at high risk to have biopsy-induced complications. There has been a recent publication studying immune-related genes coming from Canada and the United States, and showing that you can distinguish between acute interstitial nephritis and T-cell rejection. Do you have similar projects going on at the Mayo Clinic where you can basically do some kind of liquid biopsy specimen and then not perform biopsies anymore, or is that just in a research setting at the moment?
Yes, mostly research. Can you mean checking immunoprofiling of this population? Yeah, actually, I think not only us, others are doing that, but I'll give an example. That's the other issue that might affect the CRP. A patient might have colitis and they're hemodynamically unstable, and then they develop AKI. They might not have anything going on in the kidney besides the ATN from that. You're going to do immunoprofiling, cytotoxic cells, they're going to be high, everything's because of the other and that other thing, and I didn't mention before, but immuno-related adverse event outside of the kidney, also another clue that you might having a kidney-related adverse events, but in those cases, it might be confusing because you might have the CRP elevated, the retinal bind is going to be elevated because you have essentially a tubular injury on that. And then the biopsy, ultimately, you need that if you really want to know if the kidney is being affected. But if you have an extra renal immuno-related adverse event, you might go ahead and just treat it with immunosuppression anyway. But not that we are using another liquid biopsy at this moment for that. And they can be very variable patient to patient. I think if you look longitudinal in a patient, you can see high before you treat it. When they're relapsing, when they're dropping the immunosuppression, you can see the cytotoxic cells increasing. But from patient to patient, it's very variable. It's very in the beginning of the studies, but hopefully can be used in the future.
Yeah, I found the association of Sjögren's signature and immune checkpoint-induced interstitial nephritis quite interesting. And in Sjögren's, we often see different pathologies, let's say IgA nephropathy plus interstitial nephritis. How often do you see, let's say, two different pathologies in kidney biopsies of these patients, Sandra?
I have seen interstitial nephritis with those pathologies, but in general, I think like with IgA can be very, asymptomatic disease, you just know because of the hematuria, microscopic hematuria. Mm-hmm. A couple of patients, they do have very mild IgA and with interstitial nephritis. And those are the cases that I don't think the checkpoints, it's not a de novo disease, which might happen, but it's not very frequently. At Mayo, I never seen, with the exception of vasculitis, all the others, we knew the patient had already proteinuria before the checkpoint. Some are paraneoplastic. We had a case of like renoxion line with the treatment checkpoint inhibitors. And then the patient needed therapy. They start the immunotherapy. He flared up, the kidney function got, but then he just treated us with prednisone. And the patient also had other pneumonitis, other immuno-related adverse events to see. But it's not common. Most of the patients are interstitial nephritis alone.
So we are very curious, when after the start of immune checkpoint inhibitors, you usually see renal related adverse events. Can you predict that in a form?
How usually occurs 3 to 4 months, around 12 to 16 weeks after the initiation therapy. I've seen as early as 2 weeks with patients receiving combination therapy, but then they had other as well. But in general, 12 to 16 weeks. We did look to see in our studies here, we didn't have enough to check, but those who started immunotherapy by the oncologist, were they on any drug that potentially caused interstitial nephritis? we didn't reach statistical significance, but seems like those who are already on PPI or some other type of AIM-inducible drug, it seems like they tended to get it early, but I think it's just the volume was not good. So for the oncologists, I think one thing they could do, if they're on PPI, can they change to another drug like H2 blockers? We use famotidine a lot. So when they develop AIM, they were on PPI, and understand that some patients, they do need to be on PPI for other reasons. They have GI bleeding or they have very severe GERD disease. But we try to switch them to famotidine. And I think maybe I might not be correct about this, but I think it might change some decrease the risk of those patients develop interstitial nephritis related to immunotherapy.
In, I think, 2020, you and a couple of colleagues published in JASN a very fantastic work characterizing patients with ICI-associated acute kidney injury. And then I saw a patient on a gastroenterology ward and said to my juniors, well, this is a patient with ICI-associated AKI. And we started steroids, a lot of steroids, and the patient didn't recover, so he remained dialysis dependent. So what is your impression? How many patients do recover actually? How many do recover spontaneously? And how many do recover after treatment, let's say steroids?
Yeah, like what you consider like renal recovery, what you call completely renal recovery. Some studies, like most of our studies, we get 24%, 25% closer to the baseline from for this multi-center published by Gupta and colleagues. They consider 50%. So it is not complete renal response, but you can, depends what you call complete, what they determine what is complete renal response. But for these studies was an international study, around 65% of patients had completed overall. But obviously those who have AKI stage 1, 90% of them will recover. And for those who have AKI stage 3, just half of them will recover after the complete response from after development checkpoint AKI.
So I think you already mentioned it. So your first line treatment would be dexamethasone for interstitial nephritis. Actually,
we use prednisone. Prednisone is the one, and we use usually a dose 0.8 to 1 milligram per kilogram per patient. We do not pass 60 milligrams in general, unless the patient is very big, tall man. Usually you can do 80, but I've seen if I use 60 and I have a protocol to decrease 10 milligrams every week until reach 20 milligrams. And then from the 20 milligrams, you decrease 5 milligrams every week until 5. That will give approximately 2 months of therapy. There are some studies they have shown, oh, we can do much shorter time. However, in those studies, they don't biopsy as much as we do biopsy. And you can see some patient increasing creatinine by the time 1 month, especially if you decrease like 3.5 weeks, the patient will flare up a little bit. And then there's some studies, oh, I'm gonna use infliximab, I'm gonna use, there is no need if interstitial nephritis. I think if you do this protocol 2 months and just retreat the patient once they are, at their baseline, close to her baseline, or they are not flaring up the creatinine elevation, you can do if it's indicated by oncologists, obviously, do a re-challenge. But I particularly like to treat this couple of months because most of the patients I see, they are on pembrolizumab, and the half-life is like 27 days. You're gonna see flare up. And for the PD-L1, they have a shorter half-life, some of them like just 6 days. You probably can get by and treat it like atezolizumab, I think is just a shorter time, but I usually try to treat, 8 weeks around. Some may need more because they still present elevation of creatinine, and some patients are TA, they continue have the non-metabolic. The creatinine is normal, but they continue have the metabolic. So you may need to increase the prednisone or keep it for a few more weeks to get, you know. We are lucky that we see a lot of these patients, so we can have a better idea.
What about, I mean, if you consider half-life of the antibody, what about plasma exchange to reduce the serum levels of the antibodies? To use that?
No, not really. We have not used for any patients. At the most, what we use, you know, for patients one patient we had this endotheliitis that we published, we did use Anakira, it's an interleukin-1. Unfortunately, the patient didn't want to do any more treatment. He developed a significant acute kidney stage 3. He was on dialysis because he was being treated for cancer, and then he recovered right away creatinine. And at the time, it was an early one with checkpoint AKI. The oncologist rechallenged, and he was doing fine. But as his prednisone dose was decreasing, and the patient could not sleep with prednisone, he decided just cut off, not take prednisone. He came with severe AKI on dialysis. We pulsed with IV steroids. He didn't respond, and Anakira we gave, but he became comfort cares. But he was anuric, but when at home, he started making more urine. And you can say, I don't know if that helped it, but we very rarely, usually, if it's just interstitial nephritis, they're very responsible. There are some studies they have shown they use infliximab or other, but if you see the average treatments like 3 weeks, 3.5, and they're already giving, you know, other cytokine blockers, or I think if it's just interstitial nephritis, they are very well responsive.
Yeah, one last question from my side. So interstitial nephritis is basically a black hole in nephrology. There is no study whatsoever about any treatment. And of course, there has been some retrospective analysis of steroid use. Is there anything in planning that you design a randomized controlled trial steroids against, let's say, supportive care to improve kidney function in these patients to close this knowledge gap?
To do with checkpoint inhibitors? Yeah. I don't know what Dolvo would think about that, but I don't think I would not give it to someone who develop, like if you're treating with immune checkpoint inhibitor that develop AKI, I don't think I would want me randomized to the no treatment. If it's just like antibiotic, as you know, I believe it's going on a randomized clinical trial for interstitial nephritis, but I don't think I would do it for checkpoint inhibitor. I wouldn't want my family on my. If I have a biopsy, it's AIN, you better give me the steroids. But if it's the usual common interstitial nephritis, I think that's different. One thing that I like to discuss with oncologists rechallenging, you know, how when they develop immune-related event, yeah. What's your take?
Welcome to medicine. So it's individually based. It depends on how is the patient resolving. I mean, if the patient is going to renal replacement therapy, there's no question. Probably if it's end stage and the kidney is destroyed, then probably you can think about moving on. But if you do still have signs of activity and it's clear that it's immune mediated, and I think this can only be. I mean, you have referred to biopsy. Biopsy is something, it probably depends very much on centers. If you ask 10 centers over the globe, how often do you biopsy in case of, you know, increased creatinine? If a patient receives platin plus checkpoint inhibitor plus pemetrexate, and you have after the third or fourth cycle, and the patient was also a bit too dry and had emesis and some kind of diarrhea. So actually there are some points which may suggest that it's a mixture of things which happen there. Then many centers probably are not very aggressive in doing biopsies. And my feeling is also here, and also the place where I was before in Germany, that it's not so easy to convince the nephrologist to do the biopsies, because it's always the question, what do you learn in as compare? I mean, scientifically, probably you'll learn a lot, but actually clinically, you hydrate, you stop nephrotoxic medication, and perhaps you also decide to give steroids, as you mentioned, because there are signs of an immune-mediated pathogenesis of the AKI. And then if the patient improves and gets back to almost normal levels, often we also consider restarting, re-exposing the patient, because also very often the alternatives are also not very good for the kidney.
Yeah.
Perhaps they are not good for they are better for the kidney in terms of immune-mediated kidney dysfunction, but they are directly nephrotoxic. And so I think if it's a clear biopsy-proven immune-mediated acute kidney failure and you have an alternative, you would try to go to the alternative. If it's well, could be, but not clear, I stopped those medications. I gave more fluid, and I somehow stopped for a couple of times the immune checkpoint inhibitor. But now I make a second try. I think it's essential that there's an interdisciplinary management.
Yeah.
I think also here it works quite fine. So we call each other and ask and say, okay, what's your opinion on this problem? What would be the additional steps of diagnostic workup? What is there an indication for a biopsy? Should we stop, or could we immediately go on, or should we really? And afterwards, also after re-evaluation, this is often shared decision also with the patients. I mean, patients, if they profit from immunotherapy, that's much better than going for chemo, because usually the side effects are potentially reversible, and the ones which are really severe, they are really rare, also in terms of kidney function. I mean, Mayo Clinic is a huge clinic, so probably it's somehow you see more of these patients, but actually, end-stage renal failure, which is irreversible, induced by checkpoint inhibitor, that's extremely rare. I mean, we have to think about it. There are patients, but I think these are patients which have particular. They have a let's say there must be some genetic or whatever risk factors to immune-mediated kidney failure.
Or they just have already poor reserves. Some patients already advanced CKD and they develop.
Sure, I mean, but the ones which come from healthy, I mean, normal kidney function. Then
no, I agree, and that's why we learned that we are more. I try to do biopsy, especially when they are on, as you said, combination therapy like platinum, or they were on VEGF inhibitors, and you don't know.
Mm-hmm.
Sometimes the UA will not be able to help you to differentiate. We do the biopsy, at least in our clinic, if they are just pure ATN, or they are like a TMA because of VEGF inhibitors. Obviously, we try to wait the patient to recover the kidney function, get as close to the baseline as possible. But we try to rechallenge, because acute kidney injury in several studies, recurrence after the rechallenge is less than 20%, like it's around 20%. 80% of patients are fine. Obviously, most of these patients are on low dose of prednisone, like 10 milligrams, just to keep down and make sure. And some patients, at least those who I've seen, they were already in a drug, they took NSAIDs in the middle of the treatment, or their PPI. If you remove those drugs, after the first or second cycle, they are on low dose of prednisone, I say, can you try taper the oncologist to 5? And they might not develop anymore. So it might have some trigger antigen that's triggering that somehow, if you remove those drugs that trigger the AIN, it might be helpful. I know it's hard to do this in some centers, but we try to follow them closely, and they come here and access for biopsies, and very easy to do here. I say we are privileged, we can do that. But I rechallenge you like 80% on patients with AKI checkpoint inhibitors, and I don't have, especially even they might have other alternatives, but they're doing so well that we know they can do. If they develop AKI again, then it's different.
But how often is the biopsy really helping you to tailor treatment? So how often do you change strategy?
When they're in combination therapy, because you don't know, is the AKI because of interstitial nephritis or the AKI because of TMA, because they're in VEGF. And platinum therapy, usually or pemetrexed, they can cause ATN, mostly tubular injury. There is no interstitial nephritis. I let it resolve. They recover the function as best they can. And many times, as you know better, the patient with immunotherapy, they might be 2-3 months without immunotherapy and they just do fine. There is no recurrence. Some patients obviously are more aggressive, but some patients can just wait. And then when they're the baseline after a few months creatinine, you can try to rechallenge under a low dose of prednisone. So we are very comfortable doing this strategy.
But aren't also the drugs which do induce tubular injuries, such as statins, for example, isn't there? I mean, based on that's a clear effect, and we know it quite well, and we see it quite frequently. But the overall inflammatory milieu in the kidney, I mean, tubulus and the glomerulum, let's say they are not that far away. So
yeah, I understand.
The cytokine gradients induced by tubular injury also foster these glomerular changes, and that they are, because there are cytokines produced probably by incoming macrophages and monocytes, and they produce IL-1 and IL-TNF and all this stuff.
Sure, but they're quite different from, I think as a nephrologist, there is their Banff criteria. You can use the Banff criteria, even though we have biopsies, especially those who RTA very early stage of tubulitis, and if the patient was in platinum with checkpoint and is at the ATN from the blood, but then you see there is some issues with electrolytes and abnormalities that are more common with checkpoint. It's very individual, as you say, but in general, if it's just the full-blown AIN, and it's very different from ATN, as a nephrology, we know this is quite different. If it's just pure ATN, I just wait to recover to the baseline as close as possible. The baseline, the creatinine is not changing for a couple of months, and that baseline, and I didn't treat them. And obviously, I don't give prednisone for patients with pure ATN. And they just recover, you rechallenge. Obviously, I stop the platinum or the VEGF inhibitor, those are the cause of it, and just give the immunotherapy, and they just do fine. But unfortunately, or fortunately, they do need the biopsy to differentiate. Those are very small group of patients, but you get this, I would say, at least here we see once a week or every 2 weeks, we do have to do a biopsy because of those cases.
I have one additional question to both of you, actually. How large is the overlap between renal and non-renal side effects? So those people who have renal side effects of checkpoint inhibitors, are they also at higher risk for developing, say, cardiac side effects like myocarditis, or are these completely other patients?
Well, overlap side, patients who had the immune checkpoint inhibitor acute kidney injury, around 60% had the immune-related adverse event prior or at the same time. At some times, more like 20 to 30% that you can have. Usually it's helpful because they either have a rash, or oncologists, they always check the TSH. You can see they develop some TSH suppression because they develop the thyroidites that later becomes, hypothyroidism after that. So those things are common things that you see: skin rash, thyroiditis. Obviously, some GI symptoms can happen as well. Those are the around 60%, I would say, had or are having an immune-related event at the time of the immune checkpoint AKI.
It's very likely, but it's a different kinetics. So kidney is obviously something which belongs to the later ones. And I mean, when you have combined treatment, CTLA-4 and PD-1 blockers, everything appears earlier as compared to only targeting one pathway. And it's quite likely because the overall, let's say, grade 1 to 4 immune-related adverse event rate with double immune checkpoint inhibitor therapy is extremely high. So it's quite likely that those patients had prior skin is the most frequent. GI is something which happens. I would be also interested how if there's any data on microbiota and skin side effects. There's some very interesting data on microbiota and sensitivity to those drugs. There's some very recent high-ranking publications dealing with this issue in clinical settings, in addition to the preclinical work which has been published quite a while ago. And also the GI side effects can be very effectively be treated with particularly severe ones with fecal microbiota transfer. So is there any connection to microbial signatures and kidney function disturbances? No, probably not.
Not that I'm aware of, at least for the immune checkpoint inhibitors.
Not known, probably. Mm.
In nephrology, this research field is a bit, underdeveloped, honestly. The whole microbiome analysis, yeah.
And they have more like for stones, microbiota in stones, but not for the immunity.
Okay.
But it's very interesting. You're right. I've heard about the non-renal.
So I think the conclusion for myself is we need a good nephrologist, and a good hemato-oncology department to work together and to figure out the ideal strategy for a patient, because it's a bit more complex than most of us would probably expect if we see a patient in front of us.
Mm-hmm.
Maybe one last question concerning renal transplant recipients. When reading the papers on this, I found that there's also an increased risk of rejection, which surely is no surprise. Maybe also the question to the oncologist, would you be more reluctant to apply these treatments in people who have received an allograft? Surely it again depends on the underlying cancer type and on the prognosis, but would you kind of be more reluctant to go with a checkpoint inhibitor?
We are extremely reluctant on those patients. So, I mean, we have looked carefully at allotransplanted patients and checkpoint use after allotransplantation. It induces severe GVHD. Same has been published for organ transplants. You have to be very conservative in treating patients receiving an allograft. It's usually you induce problems.
Yeah, around 40%
Yeah.
at least the kidney transplant, they will have acute kidney injury from. There's some protocols they're trying to, in the past, I don't know for Dr. Wolf, but in the past year when they started, I would see and review those transplant patients. They would completely remove all the immunosuppression, may just leave on prednisone, and they would. Nowadays, I think they try to keep some immunosuppression, change from, tacrolimus, so calcineurin inhibitors, to sirolimus, and try to go from there. But the chance of AKI with transplants is very high. I think all the oncologists are very reluctant, and with good reasons. Yeah.
Yeah, I mean, also there you have to discuss it with the patient. If there are diseases which are extremely sensitive towards checkpoint inhibitors, malignant diseases, and in those patients where you do not have an adequate alternative, but you have an organ transplant, you have to discuss the risks, what can happen. And I mean, the organ transplant, nephro transplant patients, kidney transplant patients better than I do, but actually those individuals have they really like to protect their organ, their new organ. And therefore they are not very happy when you tell them, there's a really significant risk of severe rejection, which could also mean that you go back to hemodialysis, but you also have to discuss the risk of the underlying disease, and then you have to come to a shared decision. You can't say that you just go away. I think it's also an individualized decision, but we are very reluctant in using those drugs for patients.
Some patients, we are kind of luxury that we have dialysis, not like the heart, if But some patients, Dr. Wolf said, they are very adamant, I don't want to go back to dialysis. So you have to find alternatives for.
So thanks a lot to both of you for being our guest. I think we learned a lot. And for me personally, I'm now even more convinced than before that onconephrology is not just a fancy term, but really a novel field which needs experts, as Andreas has already nicely summarized. Thanks a lot. Thanks for being our guest. And we're looking forward to reading more of you, Sandra.
Thank
See you.
you. Thanks
Thanks for the invitation.
Thank you.
Sandra. Goodbye.